مرحبا، أنا منذر باسم وهذا بودكاست دكتورز لاونج، واليوم بدنا نحكي عن الاتريال فيبريليشن. في الناس اللي أعمارهم أكبر من 40 سنة lifetime risk of having atrial fibrillation is 25%. So 25% of people above 40 may have atrial fibrillation. And these people, they need your help. So let's learn atrial fibrillation together. Atrial fibrillation is supraventricular tachyarrhythmia. Supraventricular because the origin and the foci, المكان اللي بطلع منه الاريثميا above ventricles, above the AV node. So it's supraventricular. Tachy because the heart rate is more than 100. So it's fast. And arrhythmia simply means abnormal electrical activity of the heart. So it's a fast abnormal electrical activity in the heart caused by ectopic foci in the atrium. And to be more specific, it's around the pulmonary veins ostia. If you want to talk about the cause of atrial fibrillation, to be honest, there's no single identifiable cause of atrial fibrillation, but there are a lot of risk factors that can contribute to the development of this tachyarrhythmia, and we'll talk about it. But please differentiate between the risk factors for having atrial fibrillation and the risk factors for having thromboembolism in patients with atrial fibrillation. And we'll talk about that too. Now, let's dive into pathophysiology of atrial fibrillation. In order to have an arrhythmia, we need to have a trigger. And the trigger in case of atrial fibrillation is the electrical discharge from the ectopic foci around the pulmonary vein ostia and the left atrium as we said earlier. يعني في الأذين الأيسر في عنا بؤرة خارجية حوالين الأوردة الرئوية. هاي البؤرة بتكون لنا إشارات كهربائية بتسبب لنا هذا النوع من اضطرابات كهربة القلب. اوكي، صارت عنا لمدة نص ثانية ولا ثانية ولا milli seconds. In order to have an arrhythmia, it has to be sustained. عشان هيك بعد التريجر بصير عنا re-entry للسيجنال للإلكتريكال سيجنال عشان يصير عنا sustained abnormal electrical activity. This is part of pathophysiology of arrhythmias. تحديدا atrial fibrillation. ثالث إشي بيصير عنا as pathophysiology هو remodeling. As we all know, the electrical system of the heart is embedded inside the myocardium. So, sustained abnormal electrical activity will cause the atrium to undergo some remodeling and fibrosis. And again, this structural remodeling will alter the electrical activity وراح ندخل في دوامة وفي cycle ما حتخلص. Electrical abnormality بتسوي لنا structural changes structural changes بتسوي لنا electrical abnormality إلى ما لا نهاية. This is the basics of pathophysiology of atrial fibrillation. If you want to talk about the clinical features, most patients are asymptomatic. They just feel nothing. ممكن بعض patients يكون عندهم dyspnea, chest pain, palpitations, syncope, كل هاي الأشياء. But most of the patients are asymptomatic. We said that most of the patients are asymptomatic. Why do I bother myself to manage them? asymptomatic. إذا نخليهم هيك نتركهم هم أصلا مش حاسين بإشي. Well, that's not true because atrial fibrillation can cause a lot of complications. أول إشي stroke. تاني إشي acute mesenteric ischemia. ثالث إشي left-sided heart failure. Patients with atrial fibrillation, they are more susceptible to have thromboembolisms. So that's why we need to manage atrial fibrillation patients even if they are just asymptomatic. But the question is, how to know if this patient has atrial fibrillation or not? And حكينا إنه most of patients are asymptomatic. How can we know? غير إنه لو عمل هيك كان عنده panic attack فعملوا له EKG to rule out heart attack أو إجانا chest pain أو إجانا palpitations أو زار عيادة القلب لأي سبب كان ونعمل له EKG. How can we know that this patient has atrial fibrillation if he is asymptomatic? شايفين هذا التساؤل؟ خلوا بالكم لأنه راح أحكي عنه في آخر الحلقة. هلا خليني احكي لكم شو هي ال EKG changes اللي بنلاقيها. احنا حكينا انه it's supraventricular tachyarrhythmia. Supraventricular, so we expect the QRS complexes to be narrow. Why is that? Because the electrical activity راح تمر بنفس المسار الطبيعي، فال QRS complexes راح تكون narrow. أي arrhythmia above the AV node فهي راح تمر بالمسار الطبيعي. So we expect the QRS complexes to be narrow. أي tachyarrhythmia originating below the AV node ما راح تسلك المسار الطبيعي. So we expect the QRS complexes to be wide. And since AFib is originating above the AV node, the QRS complexes حتكون narrow. شو كمان؟ It's tachyarrhythmia, so the rate will be fast, above 100, typically between 100 and 175 beats per minute. ديروا بالكم ال atrial beats in case of atrial fibrillation بتوصل من 400 ل 600 بيت، بس إذا إجينا نشوف شو هو الهارت ريت بنلاقي يمكن 140 150 160. Why is that؟ هذا بسبب إشي ربنا خلقه فينا، هو من نعم ربنا علينا. تخيلوا هذا الإشي مش موجود، تخيلوا قلب قاعد وبنبض ب 400 600 بيت. That just insane. الإشي هذا اسمه AV refractory period. So it's because the refractory period of the AV node. شو كمان بنشوف على EKG؟ ما بنشوف في عنا P waves. P waves which reflect the atrial contractions بتكون مش موجودة. You can't see it. كمان الرhythm بيكون irregular rhythm، وهذا الإشي لو إجيت you're trying to feel the pulse of the patient, you can describe the rhythm as irregular. And that's a part of physical examination. Good. احنا اتفقنا انه we need to manage these patients because of the complications, even if these patients are asymptomatic. And the question is, how to manage these patients? The aim is to control the rate and the rhythm. 160 170 beat per minute is not a good thing, so we should lower that heart rate. How? The first line is a beta blocker. Beta blocker is a good medication. Side effects مش كتير serious. It prolonged the diastolic phase. Second line treatments كمان موجودة and non-dihydropyridine calcium channel blockers برضو موجودين. And the aim كمان to control the rhythm. How can we control the rhythm? The rhythm can be controlled by cardioversion. And cardioversion can be electrical or even pharmacological. Dofetilide, propafenone, amiodarone كلهم can cause pharmacological cardioversion. Radio frequency ablation is still on the table, and the indications for this intervention is symptomatic refractory AFib, if the patient prefer this, if we have congestive heart failure with reduced ejection fraction. But we need always to evaluate the pros and cons. Now, let me tell you about the thromboembolism risk for AFib patients. There is Chad's VASC criteria that you can go and Google it. I'm not gonna talk about that, but there is a rule. Any female will get 1, and 1 هذا minimum. بس لأنها female تاخد علامة. That means she has high risk. Not high risk, but higher than men. كمان الإشي القديم اللي حضلني عليه. You can Google the more complicated guidelines. 0 and 1 we give for them. If someone scores 0 or 1, we give aspirin. More than 1, we give anticoagulant. This is what I want to talk about thromboembolism. Just Google Chad's VASC. Let's talk about the atrial flutter. It's just as same as atrial fibrillation as clinical features and even management. But let me add something here. Ablation for atrial flutter is much easier than ablation for atrial fibrillation, and the specific site is in the right atrium between the tricuspid annulus and the inferior vena cava. You can find this in USMLE World Question Bank, so that's why I said this here. But let's talk about the EKG findings of atrial flutter. The EKG findings راح تكون it's supraventricular tachyarrhythmia, so زي ما اتفقنا راح تكون tacky so it's fast أكتر من 100 typically هي من 75 ل 150 beat per minute. شغلة تانية إنه since it's supraventricular so electrical activity رح تمشي بنفس الطريق والمسار الطبيعي عشان هيك ال QRS complexes رح يكونوا narrow but the rhythm is gonna be regular rhythm. We will have sawtooth appearance رح يكون عنا identical flutter waves والidentical flutter waves هم اللي بيعطونا sawtooth appearance which is pathognomonic for atrial flutter. Now let's talk about interesting arrhythmia, multifocal atrial tachycardia or MAT. المultifocal atrial tachycardia هاي بنشوفها في المرضى اللي عندهم COPD مثلا أو نيومونيا. ممكن كمان بعض الحالات التانية drug induced أو electrolyte imbalances. If we want to talk about the EKG finding, it just as same as atrial fibrillation. It's fast and it's irregular rhythm. ال P waves هون تنشاف بس بيكون في عنا 3 أو أكتر morphology of P waves and that's distinctive for multifocal atrial tachycardia. بس للأمانة it can be confused with AFib because it needs experience to say that we have more than 3 morphology of P waves and to say that these waves are P waves. How to treat MAT? It's treatable by oxygenation and ventilation in cases of COPD. We can give IV magnesium even if the magnesium levels of the patients are normal. We can also control the rate by beta blockers and we can do radiofrequency ablation of the AV node, but let's just leave that for consultant interventional or electrophysiologists. هيك بكون خلصت حكي عن ال atrial fibrillation, atrial flutter, multifocal atrial tachycardia. كان معكم منذر عناية من دكتورز لاونج بودكاست. مع السلامة.